5:30. Thank you so much, Gabby. I will pass it off to Michelle Needham to get things kicked off, and we'll get right into it. So I'll pass it off to you, Michelle.
Thank you, Rochelle, and welcome to our evening discussion of our Medicaid Transformation Project, or our 1115 waiver. This is a part of a formal federal process to hold public hearings to review the draft application we have for CMS, or Centers for Medicare and Medicaid, with our proposal to waive a few items. Some modifications to the Medicaid program do require waivers from federal law, and the mechanism is to submit an application and have discussions with CMS around that. Before we can submit the application, we need to complete our formal public hearings and gather your feedback so that we can complete that application this summer. So this is an opportunity for you to ask questions and help us think about refinements for this application today. With that, I can turn it back to Rochelle, who will be the master of ceremonies and help keep us guided today.
All right, thank you, Michelle. And let's go to the next slide, please. All right, so today we are recording our webinar, or our hearing. And so with this time, we have muted all attendees, which means that you can hear us, but we can't hear you yet. There's going to be time at the end for Q&A, and we encourage you to submit your questions and comments through the chat function in Zoom. And you can do this during any part of the presentation. You don't need to wait until the end to ask those burning questions. You can just fire them off as they come up. And if you wish to verbally share your input, and we encourage that too, please just raise your hand using the raise hand function, and we will call on you during the Q&A. And the raise hand function is under the reaction section of Zoom. So we've turned on closed captioning for all attendees today, but you might not see it on your end. So if you want closed captioning, please enable the live caption button at the bottom of your screen. The slide deck that you're seeing today is available now on our Medicaid Transformation Project renewal page, and we will be posting the recording from today's hearing on the same page in about a week or so. Next slide. All right, so today's presenters. So you just heard from Michelle Needham, and she is our Chief Policy Officer at Healthcare Authority, or HCA. You'll also hear from Michael Arness, and he is the Deputy Chief Policy Officer at HCA. We'll hear from Bea Rector, and she is the Interim Assistant Secretary for Aging and Long-Term Support Administration, also known as ALTA, within the Department of Social and Health Services, that's DSHS. And finally, we'll hear from Chase Napier, and he's our Medicaid Transformation Manager at HCA. And I'm the moderator, the Q&A person at the end. My name's Rochelle Alongi, and I'm the Policy Communications Manager for HCA. Next slide, please. Okay, so really quick, our agenda. We're going to do a quick overview of Medicaid and of our Medicaid Transformation Project, also called MTP, our waiver renewal. And we'll dive into some deeper thoughts on the goals for the renewal, and then also talk about those programs that will continue, expand, or begin underneath the renewal. And then, of course, we'll have some dedicated time at the end for Q&A. Next slide, please. All right, so Michael, I'm going to pass it off to you to talk about Medicaid.
Thanks, Rochelle. Michael Arness, Deputy Policy Director, and good evening, everybody. The Medicaid program is administered by the state and federal rules, and it's funded with joint state and federal money. When we want to operate a new demonstration program that is not supported by the federal rules, we are allowed to request a waiver of the Medicaid rules to do such. And we are under a waiver right now, operating demonstration programs since 2017, and that's the Medicaid Transformation Project. And then if we can go to the next slide, we're going to talk tonight about the renewal of that Medicaid Transformation Project so that we can continue demonstration projects. And we have three aims for this: to ensure equitable access to whole person care, empowering people to achieve their optimal health and well-being, and to build healthier, equitable communities with communities and pay for integrated health, equitable, value-based care. Next slide. And we also have organized the mtp-renewal for the next 5 years by 3 goals. And we'll be doing the presentation tonight around those 3 goals. And the first is to expand coverage and access to care, ensuring people get the care they need. The second is to advance whole person, primary, preventive, home and community-based care. And third is to accelerate care delivery and payment innovation focused on health-related social needs. And this is a takeoff in the area that we have been primarily working the last 6 years with accountable communities of health. And we now have some additional innovative programs that we would like to propose to our federal partners. The next slide, we'll go into a deeper dive into goal number 1. Let's go on to the next slide. And these particular areas here are either supported by the Washington State or suggested by the Washington State Legislature or directed by them. And we were able to find a path forward within the waiver, at least to propose a path forward in the waiver. And the first is continuous Apple Health enrollment for children up to age 6, which would mean that once a child is found eligible for Medicaid, we would no longer continue to review the income eligibility standard, but all other eligibility standards would remain in place. And that helps just end the churn and make sure that we don't have gaps in care for that valuable period of coverage from 0 to 6 years. The second area, actually this one directed by the legislature, is for reentry coverage for services after incarceration. And this would restore Medicaid coverage for people leaving prison or jail for up to 30 days prior to release. And right now, the person remains eligible, but their coverage for Medicaid is suspended. And so by having this particular program in place, we would enable a smooth transition to ensure people get access to critical care, because we are finding that sometimes within the first day or week of someone being released, not being connected to the medical system is poor for their health. And sometimes we're even losing people within those first few days. So we do believe that this will be an attractive program to discuss with our partners, our federal partners. On the next slide, we're going to talk about what we call postpartum care. And this is Apple Health coverage for people after the pregnancy ends. And this is actually supported today by some federal rules. And so we would like to continue to expand our coverage from 2 months to 12 months after pregnancy ends, and also extend the coverage to other individuals who were possibly not connected to the Medicaid program when they had their pregnancy and delivery. And then supports for people receiving treatment for in what we call some designated settings for mental health and substance use disorder. And these would be inpatient settings. And what this allows us to do is to continue those inpatient services for mental health and substance use with the support of federal dollars. So not just paid by state dollars, but also with federal dollars. And this just enables us to make the best use of inpatient care for mental health and substance use disorder treatment. Next, we're going to get into, I believe, goal number 2, and I'll just read this real quick before handing off to B, but advancing whole person, primary, preventive, home, and community-based care. And I believe B. Rector is with us tonight. Let's go on to the next slide. And there you are, B. Thank you.
Thank you so much, Michael. I really appreciate this partnership with the Healthcare Authority. Again, my name is B. Rector, and I'm the Interim Assistant Secretary for the Aging and Long-Term Support Administration. And we have been partnering with the Healthcare Authority on the current 1115 waiver. And in this renewal, we really are looking for extending the current services that are being provided which are services for unpaid family caregivers that are helping individuals with disabilities who are 55 and older to stay in their homes. And we're wrapping services around those unpaid family caregivers to help them in doing that. We also have a service called Tailored Services for Older Adults. And that service is really targeted to individuals that are not financially eligible for Medicaid, but they do meet the functional criteria to receive Medicaid-funded long-term services and supports. And this is a way for us to wrap a small benefit package like personal care, home-delivered meals, housekeeping and errands, those types of things around individuals, again, so that they can stay at home longer and delay entry into the Medicaid-funded long-term services and support system, and hopefully delay the impoverishment that happens in order to qualify for Medicaid funding. In this 1115 renewal waiver, we're also asking for some additional flexibilities from the Centers for Medicare and Medicaid Services around 4 things. The first is that we know that there are individuals that currently are stuck, for lack of a better term, in acute hospitals, in psychiatric hospitals, or in skilled nursing facilities. They do not have a family member that can act as their guardian, and they lack decision-making capacity. And so they're really not able to transition out of those institutional settings to less restrictive settings unless they do have a guardian. And because of their limited income on Medicaid, they really don't have a way of paying for one. So we're seeking some flexibility from CMS to potentially use Medicaid dollars to help these individuals with decision-making support so that they can transition out of institutional settings. The second flexibility we are asking for is an expansion of presumptive eligibility. Under the current 1115 waiver, for people trying to access our Medicaid alternative care or tailored services for older adults, we're able to do a brief screening of functional criteria and financial criteria. And based on that screening, we can make somebody presumptively eligible to receive services. That really means that we can start services quickly while individuals complete the full Medicaid application and while we do our work to make sure that they're eligible from an asset and income level as well as a functional level. We want to expand that presumptive eligibility screening process to all Medicaid-funded long-term services and supports. That would really meet the policy goal of putting access to home and community-based services on par with people accessing Medicaid for services in a skilled nursing facility. The third flexibility we're asking for is to be able to coordinate personal care differently in situations where we have multiple people living in close proximity to each other. Good examples of that would be multiple people living in an apartment complex, living in a mobile home park. Currently, delivery of personal care is a very one-on-one kind of scenario where you've got one worker connected to a single client, and there tends to be a lot of downtime. What we would like to do is to be able to pool resources, pool the hours, create teams of workers who can support multiple people. We think this will expand the available hours that people can access care. And we also know that it will stabilize the hours that workers are paid and allow them a higher job quality and more teamwork, which is something that they have really asked for over the years. And then the fourth thing that we're asking for is funding for rental subsidies. There are some real institutional biases kind of baked into Medicaid. And one of them is that if you live in a nursing facility, we can pay for room and board as part of our Medicaid rate. But if you live in your own home, we can't pay for rent. We are looking to test out a model where we would be able to pay short-term rental subsidies for individuals that otherwise are in an institution like a skilled nursing facility or a hospital, and where it is more cost-effective for the state and the federal government to pay for personal care services and some rental subsidies on a monthly basis that would be cheaper than what we're paying for somebody to be served in that institutional setting. So we're super excited to have these critical policy conversations with the Center for Medicare and Medicaid Services. And we'll see where those conversations go. And with that, I will turn it to Chase, I believe, with the Healthcare Authority.
Thanks, B. Let's go to the next slide here. There's one other element under goal number 2 that I want to cover, and then we'll get into goal 3. We want to continue our work on integrating physical and behavioral health, specifically through a standard assessment for physical and behavioral health providers to really assess their current standing along the continuum of integrated care. And then ultimately, beyond providing the standardized assessment, it allows us to offer practice coaching and support to advance along the continuum. And we'll also be asking for some flexibility to provide incentives based on a targeted basis to providers to reinforce that progress along the integration continuum. So this does build upon some work to date, but we're really launching a new standardized assessment tool known as the Washington Integrated Care Assessment. And it's based on a lot of input from those who participated in assessment efforts prior to today, and also based on input from accountable communities of health and managed care organizations, and those who have worked with providers in both behavioral health and physical health settings. So really excited about this. And this is also included in goal 2. So if you're in the application, you'll find it there. Let's go to the next slide here. So a deeper dive into goal 3. And as Michael mentioned at the start of the call, a lot of this work builds upon some of the partnership with accountable communities of health and managed care organizations, as well as the Foundational Community Supports Program. Ultimately, we are looking to accelerate care delivery and payment innovation focused on health-related social needs. So we're going to start talking a little bit about all of those really important connections and supports that exist beyond the healthcare. Let's go one more slide. So within the application, you'll see that we talk a lot about a program called Taking Action for Healthier Communities, also known as TALK. And this is an opportunity to address health-related services, which we'll talk about in a minute, provide health equity funding, and implement community-based care coordination known as community hubs, including a native hub and community-based workforce investments. We'll unpack all of that a bit more. And then under the TALK program, we will be partnering with accountable communities of health, managed care organizations, tribes, and other partners, and really strengthening the collaboration across those sectors and organizations. Next slide, please. So in terms of addressing health-related social needs, first, let's start with what we have today and what's working really well. The Foundational Community Supports Program. So FCS provides supportive housing and supported employment services to some of the Medicaid population that most need those services and have complex care needs. FCS does not pay for housing, wages, or wage enhancements. We've seen just a lot of really good success in our early evaluation results and what we've heard from community members and providers. We're excited to continue the Foundational Community Supports Program. And in fact, we're excited about 2 enhancements to the program that we're going to be seeking under the renewal application. So the first one would be to allow the program to pay for one-time transition costs, such as application fees, basic home goods, first and last month's rent. The second would be regarding eligibility and extending the eligibility for those exiting a correctional facility, and also for individuals who are age 16 or older. So mostly continuing, but a couple of enhancements. And then, so a look ahead to health-related services, also referred to as HRS. So I want to talk about a strategy called In Lieu of Services. This is a managed care authority that we have the ability to use. And it is an alternative service to clinical care. So they have to be considered medically appropriate alternatives and have to be considered cost effective. alternatives. So a good example is removing carpet in the home of someone with asthma, where we know that those carpet conditions is just going to continue to cause issues, and we could provide great medical care, but really we have to address some of the underlying issues. So that would be a great example of the type of alternative service. It's not medical care, but it's very much medically appropriate and cost effective in the long run. So there are many services we have in our application that are on that proposed list of health-related services. And these are funded through managed care organizations. In fact, some of these are available now, and MCOs do provide some of these in lieu of services now. What we're trying to do is to expand the list of services and streamline the approval process. So by creating a kind of a pre-approved list, we hope to increase the use of these services, really to normalize the use of these services. And then there is a connection to the waiver. So these are services that can be paid for through managed care, but the reason we're including them in the waiver is because it's so connected to the goal 3, the health equity investments, the community hub work. So we'll talk about the connections there that really reinforce this opportunity, but also because some of the services may not be approved as in lieu of services, and then it just gives us a really great transition opportunity to pay for them as waiver funded services if they're not allowable as in lieu of services under managed care. And we've seen a couple of examples of that with other states, such as California, that had a really similar strategy. Let's go to the next slide. So the health equity programs, we are really excited about the broad focus on health equity across these strategies. What we're talking about here is not the only focus on health equity, but it is a really concerted effort to make investments in community. And these are, we just talked about health-related services, which are really at the individual level, the services necessary for addressing health-related social needs. Now we're talking about infrastructure, organizational supports, capacity building that is important beyond individual services. This could be an opportunity to help organizations get ready to provide health-related services. So new organizations that could be under contract with managed care organizations. It could be community infrastructure that's necessary to achieve health outcomes and to help community members access services, access care. So we're really looking at both individual services, but also community investments and capacity and readiness funding. So that's where this fits in and really reinforces that idea of health-related services. There's more details to be worked out for this health equity program. So more definition and parameters will need to be developed. But we're really excited about this. I think this is, a really great opportunity to use some of the waiver funding for these health equity investments and community infrastructure that oftentimes is under-resourced and can get overlooked. Let's go to the next slide. All right, so in the context of community-based care coordination, we have this concept of community hubs, native hub, and community-based workforce. So we are proposing that each ACH, the accountable communities of health, and there are 9 regions that the 9 accountable communities of health comprise. And we're anticipating each of the 9 to oversee a regional community hub, and then there to be 1 statewide native hub that would improve coordination between Indian healthcare providers and other community organizations. Again, this really reinforces the delivery of health-related services. So as we are implementing new services for alternative services and community supports, this is another mechanism to help identify the needed services and refer individuals to those services, and also to support the readiness of those organizations and the network of community-based organizations that will be really important for the delivery of health-related services. And this is not about replicating clinical care coordination or replicating any other community care coordination that exists. This is meant to be a reinforcement and a connection and a resource and referral resource and navigation opportunity, but not not the medical care coordination and not replacing those referral processes that work really well today. But we know that there's opportunity for improvement, opportunity for more connectivity, and even opportunity for some alignment in terms of how we do screening and referrals and navigation to resource directories, etc. And then community workforce payment. So we know that there's also a gap in terms of how we pay for community-based workforce, and we're using a general definition there. We're not saying community health workers or peers or navigators. We're really meaning broadly, how do we support community-based workforce, which could be any number of definitions. Let's go to the next one here. So some of the functions, and I've touched on a couple of them. We want to engage individuals and screen for social determinant of health needs. Again, this isn't the only scenario where there would be a social determinant of health screening process, but we see opportunity here. And then that network of community organizations is going to be really important so that we can make referrals once we identify needs, make referrals to the organizations that can address those needs, get those patients and individuals connected, and then follow up, make sure we understand what's happening. Are we completing those services? Are we getting the supports in place for those individuals, and tracking outcomes, and even closing the loop so that organizations understand when referrals are made, what's happening to those individuals they're referring. Let's go to the next one here. And then one more element on community-based workforce. So within, I just talked about the community hubs. We do think that's going to support community-based workforce capacity and payment as we continue to look at Medicaid payment opportunities and sustainable Medicaid payment opportunities. One more specific community-based workforce strategy is a pilot that was authorized by the Washington State Legislature specifically for community-based workforce placement in pediatric primary care. And so there was $2 million in state funding authorized to support the pilot. We're going to pursue federal match because pilots for this type of work are something you can include in 1115 waivers because we're testing and evaluating. And so we can include this and seek federal match that would just reinforce this pilot and allow us to provide more funding for community-based workforce in alignment with the legislative direction for this pilot. So we're excited about that as well. It really goes really cohesive, a cohesive alignment here with the goal 3 and the community hub work. So a great opportunity. And just a couple more here before we get to discussion. Just wanted to summarize kind of a snapshot here of what's continuing, what's expanding, what are we really just starting. So just to kind of a refresh from everything we've covered. So we are continuing without any changes the substance use disorder and mental health IMD waivers that Michael talked about. We are continuing the existing MAC into SOA programs and the existing FCS program, but we are expanding some of those long-term services and supports, flexibilities that be highlighted, and then for foundational community supports, addressing the one-time transition costs and the eligibility expansion. And then we're beginning several new initiatives we're really excited about. The Taking Action for Healthier Communities program and what that includes that I just covered. And then Michael covered the continuous Medicaid enrollment, the extended coverage for postpartum, and reentry coverage after incarceration. And then there's the community-based workforce pilot that I just covered. So lots of really important work we're really excited about. Let's go to the next slide here. We're almost to discussion. So just as a reminder, all programs and policies are subject to negotiation. So we're really enjoying the public comment process, getting feedback, having really important conversations that will lead to a final application that gets submitted to CMS. And then eventually that opens the conversation and negotiation with CMS. So we're hopeful that we have a really strong proposal, but all of this is subject to their approval. And then, of course, all of this requires time for development. Obviously, the newer programs, will have some implementation and startup and capacity building to a greater degree than existing programs that can just continue without any delay. And so we just need to be aware that some of these may be phased in over time and require some ramp up. And if we get approval by the end of 2022, we don't necessarily start on January 1st. So there would be continuation for programs that exist today so that there's no gap in implementation and coverage of services such as MAC and TSOA and foundational community supports. But that doesn't mean that everything is ready to go on January 1 of 2023. Rochelle, I think, let's go to the next slide. I think it's back to you. Yep.
Yes, thank you, Chase. And thank you also to Bea and to Michael. So we've got some key dates to go through really quickly. Last year, we spent some good amount of time developing these concepts and engaging with key partners. The earlier part of this year, we continued the partner, tribal, and community engagement and continued to refine those concepts. And right now, we have 1 week left in our formal public comment period. That started May 12th, it ends this coming Monday, June 13, and it's our time to be able to hold these public comment webinars and also gather feedback in other ways and hold tribal consultation with our tribal nations in this state. So that's what's happening now. And coming up summer 2022, we do plan to submit our final application to Centers for Medicare and Medicaid Services, or CMS. And a big part of the formal public comment period right now is to gather all the comments that we receive and to use those to refine that final application. So that's where we're at. Next slide, please. Okay, so now is the time where we get to turn it back to all of you who are listening and who may have some questions for us. It can be a little bit overwhelming. We've given you a lot of information, and so we've kind of crafted this slide here to kind of give you some ideas of what to think about, of what you might want to talk with us about. So when you hear about this renewal package, what's exciting, what concerns you? Is there anything that you want to make sure that we know? What's working well now that should be preserved in the renewal? Is there any other feedback that you would like to share with us? And I know we've got a little bit of a smaller group with us this evening, but we are so glad that you've joined us and that you've took an hour out of your evening and busy schedules these, this time of the year. Really appreciate all of you in attendance. So I think while we're waiting for folks to write out their questions, and again, you can raise your hand too, and we're happy to do it that way. Let's go to the next couple of slides. So we've got some public comment alternatives. So if you're not wanting to provide comments today, that's totally okay. We have other ways that we can grab your feedback. You can email us at medicaid-transformation-project-mtp@hca.wa.gov. We also have an online survey that is an open text. You can plug in lots of words in there, and then it isn't you're not limited to the amount of characters there. So we have an online survey, and then you can snail mail us as well. Let's go to one more slide, and then we'll go back because I'm seeing we've got a question in the chat here. So we've got some resources for you. We have the Medicaid Transformation Project Renewal webpage, and that's our URL for that page. And on it, we have all of the information on the renewal. We also have links to the full draft application and the appendices. We have an acronym glossary so that folks can kind of better navigate the application, because the state, I think, is a bit guilty of using acronyms quite a bit, because there's so much work that we do, and sometimes it's just a little easier to use an acronym. So we have an acronym glossary to help all of you navigate through that. And then we also have a few different publications. We have an About the MTP Renewal and a snapshot document. And both of those are basically condensed versions of the draft application. And both of those documents are in multiple languages. We also have the evolution of Initiative 1 that covers a little bit more about our accountable communities of health and also what they'll be focusing on and other partners will be focusing on in the renewal underneath the Taking Action for Healthier Communities, or the TALK program. And then we have an FAQ. There's also an option on that page to subscribe to GovDelivery announcements. We do send out quite a few, especially during this time. We want to make sure that the public and our partners and other folks are just in the loop on what we're doing. And that's a great way to have, directly to you information from us about what we're doing. So let me go back and see what we've got here. So give me just a moment. We are coordinating behind the scenes. We've got a number of subject matter experts along with our presenters from today, and we want to make sure that we line you up with the right person here. So hang tight for just a moment and I'll be right.
Michelle, I'll just take a stab at it. This is Michelle.
Oh, sure. Thank you, Michelle.
And the team can jump in if I'm leading us astray, but thank you for your question about the end-stage renal disease and the payment for some of that service within the Medicaid program. This program around the waiver doesn't include changes for that or the specific benefits or the payment for services. So I think your specific question was where to submit comments around that need. And I would say, go ahead and send a letter to us. We'll forward it to the program. It really becomes a legislative budget discussion and the need to have that discussion in the upcoming legislative session and our submittal to the governor's office for the budget proposal, which is due in September. So there is a lot of budget development work that is completely separate from the waiver components. And if there's someone from the team that wants to round out, feel free to jump in.
No, thank you, Michelle. I think, I suppose the only thing we might do is just to copy the website into the chat, possibly on where to submit comments. And even though, but I think it's right there at the bottom of the slide too.
Michelle, this is B. The only thing I would add is if there are more details on the question or comments around the home helper program, I'm not sure if they're referring to personal care services provided under Medicaid, but we do a lot of transportation and personal care assistance for people while they're undergoing dialysis. So if they want to add that into the letter, HCA can get it to us if it applies to our programs.
Perfect.
Thank you. And I'm just putting in a note right now. I'm going to be pasting in our MTP renewal page link. And in that link, you're able to access the survey, all the resources I just shared, all of the stuff is on that page. So, and it's toward the bottom underneath resources. So I'll shoot that out in just a second. And in the meantime, we are still available if any of you have any questions or comments.
I see Rochelle, I see the comment from Craig, and I just appreciate that feedback. I don't think there's a question in there, but we do appreciate the feedback on what's working well and what you'd like to see continue, and the success of the Pathways tool, something we have taken note of, and we continue to work with accountable communities of health, and we're going to work more closely with managed care organizations as well on the future community hub work and how to build on what has really been successful and instrumental over the past several years. So we appreciate that feedback and your ongoing work, and we look forward to any comments you have on that too, to incorporate in our public comment process.
Thank you, Chase. And we really do appreciate the comments and questions.
I would like to make a comment, but before I do, I'm curious if Craig, you would either share verbally or via chat why you think that, you would like to see pathways roll out more broadly beyond ACHs?
Sure. If it's all right if I talk, I'm not trying to take the floor from the healthcare authority, but yeah. So there has been, first of all, kind of a disconnected rollout of pathways in the state of Washington. And I think different communities had different levels of success. And we did a pretty broad study of why that was. And there were a couple of things that were consistently reasons for communities not to have the success with pathways in the rollout. And so I think that if there was a little bit more consistent rollout statewide, I think that the legislators are very excited about the concept of outcomes-based payments and having a tool. It doesn't have to be pathways. Pathways is a good one that is used by the organizations that are providing the broad network of social determinants of health, and especially homeless housing support all across the state. There needs to be a tool. And I think the legislative voices are all coming together on both sides of the aisle saying there needs to be a tool in place for these agencies, because it's been kind of a house and hope model in our state for a long time. And I'm not trying to throw stones at anybody. I've been there as well. But what's happened is we haven't, the way it was rolled out with all the ACHs was some had success, some didn't have success. It was a little bit hit and miss. And there have been a lot of agencies that have come to our organization, looked at what we're doing and have said, hey, we want to do that in our community, but we can't because our ACH isn't doing that. We would love to have this tool rolled out. And to give you an example of how I've had over 20 agencies come to my agency and ask to be able to roll out pathways in their community, but they can't because the ACH they're working with doesn't do it for whatever reason. Is that helpful?
That's super helpful. Thank you. I would like to hold my comment and if there's time at the end after everyone else has shared comments and questions. But thank you, Craig. I really appreciate you sharing that insight.
Yes, well, please feel free to share your comment. You know, this is an opportunity for those who, you know, who showed up to share. So, you know, please share with us. We would love to hear from you.
I'd be happy to. And I would love to hear everyone who's here. I would just love to hear your thoughts on what I'm about to share and kind of what your own experience has been, and if your experience aligns with what I'm about to share with you all. So hi everyone, my name is Stephanie Boltema. I'm participating today as a community representative and a PhD candidate. And I would like to speak to something that I think is working now and should be continued. So over the last 5 years, I've been conducting rigorous research to learn how accountable communities of health, or ACHs, in both Washington and California, and you know, ACHs are even beyond those two states, create systems change and improved equity in their communities. The feedback that I'm sharing today pertains to the critical role that ACHs play in Medicaid transformation and serves to advocate for their continued leadership in these efforts. So over time, my research has demonstrated that the causal link between ACH creation and better outcomes for communities. Because of ACHs, communities are better connected and better poised to make system level improvements than ever before. ACHs create systems change by working with cross-boundary groups to define a shared vision for their community, shift power structures, and normalize those power shifts. Evidence shows that these collaborative actions lead to communities having better knowledge of their system, working together as a cohesive system, that partners are better able to serve their clients and reach their goals, and they're able to deliver better service outcomes. Furthermore, my research has shown that ACHs improve equity by ensuring procedural justice in collaborative processes, by building trust across boundaries, and by ensuring distributive justice throughout communities. Evidence shows that these collaborative actions lead to improvements, expansion, and greater accessibility of community services and resources, all of which are known to be directly linked to improved equity at the population level. ACHs create equity, understanding, and competency in their partners in a way that exponentially shifts mindsets, practices, and policies toward an equity orientation. My cross-state mixed methods research shows that ACHs are creating the upstream and systems level changes we know need to happen to improve equity, reduce health disparities, and create a healthier, more just society for all. Thank you all so very much for this opportunity to comment. And I'd love to hear if other people, like what you think about this, what I've learned through this research, if your own experience matches it.
Thank you very much, Stephanie, for your thoughts. And I will turn it to the team if there's anything that we would like to say. And of course, we would certainly welcome some dialogue from attendees too to share.
Rochelle, can you see the hand up for Kay Jones?
No, that's me with my one little screen. My apologies, Kay. Yes. Have you unmuted yourself?
Yes, I have.
All right.
So pardon me for the the abbreviated identification. So my name is Kevin Jones, and I work with Sisters in Common out of Renton here in King County, Washington. And to, I believe it's Stephanie, to her point, she talked about establishing trust to get better outcomes. What we realized was helpful was leveraging existing trust. So all of the community health workers are from the communities that they serve. We got buy-in from the leadership of those communities, who then recommended community health workers, and for lack of a better term, are the governors to an extent. When someone gets nominated to work for the community, they're held to account by their community, in a positive way. And that's enabled us to have a handful of community health workers working part-time, deal with literally more than 300 clients in the last couple of years. And they'll get a good morning call at 7 a.m. They may get a call at 11 o'clock at night. But they're highly effective because, again, they're of the community. They speak the language. They understand the culture, boundaries, both positive and negative, in terms of what to do and how to do it. And much of the innovation that we've done with the use of community health workers came through the funding of Healthier Here, which is the accountable community of health in King County. And they've been extraordinarily supportive in terms of funding, giving us the latitude once we describe what we want to do and how we want to do it, to say, hey, do it your way, let's see how it works out. And when it works out well, we've been able to obtain their continued support for future innovation, including a current community innovation project that will go on for the next 2 years.
Thank you very much, Kevin. I appreciate your comments. All right, and it looks like we have another question from Reed. Thank you so much for putting a question in there. Give us just a moment and we can confer behind the scenes here and see about addressing your question. So stay tuned for just a moment.
Michael, do you want to take a stab at this one?
I do, thank you. And Reed, thanks for the comment. I think it unearths some things that need to be clarified. First of all, yeah, Community Information Exchange, or CIE, is meant to be the health information technology, or in a sense, the IT undergirding that's necessary, we believe, to help operate community hubs. And we see the community hub more as the people, the workers that Chase was talking about, and the people who are connected with their community, who know the priorities, who know the health-related services that are most needed, and can do the job of working with individuals, with Medicaid clients, to make sure that they receive the health-related services that they need, and that it's done in a coordinated fashion. And that there is, not just a referral that is performed, but a referral, and we know that some service was performed at the other end, or what sometimes is called closed loop. So Reed, thank you. I think it does create some confusion when in the way that we talk about community information exchange. And we are actually only mentioned, I think, community information exchange, as you mentioned. We only mentioned it twice in the application, in part because we do want to emphasize the community hub, the actual people side of this service that is performed. We want to emphasize that to our federal partners, because that's the part that we want them to approve. And something we could get into more is that we're actually trying to fund community information exchange through a different mechanism than this waiver. However, we still want to fund community information exchange and have it come up and be a solution for the state. So you mentioned there may be 10 different systems across the state. So let me talk about that for just a moment as well, because there has been some investment actually through the waiver funds and other funds into community information exchange in some of the accountable communities of health, and we want to leverage the investments that are made. We don't want to water them down or make ACHs start over again. We believe that when we bring a community information exchange solution into the state, that we can link those systems together and build a community information exchange strategy across the state, so that it really operates as one system. And in that sense, we don't have to tear down the investment that has already been made in certain communities. And we also can leave open to communities that they can purchase the community information exchange system that works best for them. The commitment from the state when we talk about bringing in a solution is that we would like to be able to make sure that we, again, link those different CIE systems together, and so that they can operate in a single strategy across the state. So let me read your question. The procurement is deferred to each ACH hub. The state does plan, we're doing a review right now, so we are trying to put together an approach for that, for how to implement community information exchange, but we would like to support each ACH as well. So yes, it would be a choice at this time that an ACH could make with the hub, but we believe that the state can be there to help with expertise as well, and we hope to help with funding. Right now, we've been asked by the legislature to do some work around how we might best do a CIE solution throughout the state. So we need to put that review together and get some buy-in from the legislature on how that would work. But our hope would be that that ACHs would have a choice and that the state would be there to help out.
This is Reed. Just a quick thank you, Michael. A bit of a puzzle, but well communicated there, and I followed completely. So thank you for that response.
Yes, thank you so much. And I think and I appreciate the comment, Reed. Maybe we can clarify a little bit better before we draft the final of the version that we submit to the federal partners. So thank you.
All right, thank you, Michael, and thank you, Reed. So we've got just a few more minutes left before our 6:30 time is up. The floor is still open for folks that want to share. And I'll give us another minute. And we are very appreciative of the comments, and I want to make sure that folks have a chance. I know a lot of the comments and questions have been long, and it takes a while to type out. So we are here to answer.
Rochelle, if I could, I see that Kevin Jones's hand is up again, and I know that you can't see it. So if,
Thank you, Michael. Yes,
Good.
Kevin. Yes.
Hey, hi there. So I have a CIE specific question with a bit of an interesting bit of background. So I was an invited technical expert in the RFP process for Healthier Here's vendor selection for implementing the CIE in King County. And to the point that was raised by Reed, is the expectation that CIEs from around the state will be integrated so that they maintain independent operation but cooperate with each other, or that there'll be some independent sort of regional level CIEs and then one state level CIE?
Kevin, thank you. The former.
Okay, so integration.
Yes, we're definitely trying to avoid the latter.
Okay, cool.
Yeah.
That's helpful.
Yeah. And Kevin and Rita, part of my response tonight is that we have been asked by the legislature to do a review of community information exchange in the state and to make recommendations.
Mm-hmm.
So I'm trying to honor that process and not get out too far ahead on suggesting a solution, but I think any solution that we suggest would be linking or integration. Kevin, you're spot on with the terms of systems. We would like not to have to go around the state. As Washington State, we would like to not go around to communities and dictate which of these systems we think works best in the communities.
Mm-hmm.
I think our responsibility is to help with standards and to help with integration and to help with policy setting and funding. And I think the recommendation that we make in return to the legislature's request will probably involve all of those. But we need to make our case to the legislature first, and then move out with a more solid proposal or explanation to people like you and Reed and everybody else on where we think we can go with CIE.
Understood. I've been a part of some standard committees and working groups for the World Wide Web Consortium in the past, and standards are a good thing. That gives people a requirement for how to work together, but no insistence on how they do that work under the hood.
Nicely said. Yes, thank you.
Thank you. All right, and I will read out Stephanie's comment. Hi all, to Reed's question comment, this network map demonstrates the need for a statewide CIE system. ACH participants across the state are all connected through referrals, data exchange, and collaboration. Some sort of coordination across CIEs at the state level is clearly necessary. And there's a link here for folks to go to. Thank you very much, Stephanie. And I think we've got time for one more question. I see that Kathy Knight put in a question on area agencies on aging. Bea or Debbie, would you be able to answer this one?
This is Bea. I think we acknowledge the long-standing partnership with our 13 area agencies on aging in our state. They're a critical partner in the delivery of Medicaid-funded long-term services and supports, and they've been really the front door to administer the MAC and TSOA program under our existing 1115. So I think Kathy is weighing in with her support and appreciation for the partnership and acknowledgement of their critical role in the 1115 services and in the overall long-term services and support system in Washington. And thank you, Kathy, for participating tonight. We appreciate that.
All right, thank you, Bea. Thank you, Kathy. All right, so we are right at 6:30, so we're going to wrap things up. Thank you all so much for the great engagement and dialogue and questions and comments. And if anything else comes to mind, please go to our MTP renewal page and you can provide comments a number of ways that way. So Thank you again. Be well, and we'll be talking with you soon. Thanks, everybody. Have a good night.